Everyone. There it is. Okay. Hello, everyone. I hope you're having a good morning, afternoon, evening, whatever you are in the world. I'm Vale. I'm one of the CP Solvers team members, and it's been a long time since I've been on VMR, particularly discussing a case, which is the role I'm taking today with Ravi, which is very exciting. So if you have any case that you would like us to discuss in these 30 minutes, please put it in the chat. We would love to hear it. And also, if you have any thoughts on the discussion itself, you can also put it in the chat and we will highlight that for sure. So for the people that don't know me, because again, it's been a while since I've been on VMR, it's been a couple busy months. I'm a medical student from Lima, Peru. I really love neurology, ID, and the CP Solar family. So yeah, I'm really excited, and I pass the mic to Ravi.
Hello. Raise your hand if you missed Vale. Woo! So nice to have you back. Give me 1 sec. Someone's knocking at my door.
Do you think that we'll be able to get the guy in bed 11 to ride home if his ride leaves?
Yeah.
For sure.
Totally.
Okay. All right. Thank you. That's all I need.
Thanks for checking. Sorry, Vale. I am at work right now, and it's a little busy, but there's always time, 30 minutes to hang out with you all. Yeah, Vale, it's so nice to have you back. I'm super excited. It's been a long time, Vale. There are many people who are not part of VMR. I think when Vale was lighting up the VMR scene, and excited to see that in action again today. Any of you guys have a case that you want to present?
It doesn't have to be neuro or ID. I mean, if it is,
I love the caveat.
I will love you, but it doesn't have to be.
Okay.
It can be anything.
Awesome. Well, I think Ravi was kind enough to volunteer a backup case that he has. So Ravi, as always, will lean on you, and I really appreciate you keeping us VMR educated.
I was taking a few minutes to look for an ID case, but I'll just go with what I have.
All right, Vale, there's our first clue. It's definitely not ID.
All right, so we have a 23-year-old female who presents with chest pain for 1 day. That's the first aliquot.
Chest pain for 1 day, you said, right? Okay, so I think the first thing that comes to mind is, well, I love neurology. So for me, everything, it's pace and localization. And definitely first starting with pace, the acute onset of chest pain, of course, makes me prioritize different things. But I think for chest pain specifically, the anatomical approach is really helpful. So I will start with localization. And in that setting, I mean, you can think about everything that's on the chest, right? The lungs, the heart, the ribs, even the muscles can cause chest pain. And then other more miscellaneous things like, I don't know, like something metabolic causing pain, or something abdominal or from the back that could migrate and seem like chest pain. However, when it comes to the to chest pain localized to the chest, the lungs and the heart are the first things that come to mind. And in that setting, especially because it's acute, I would like to rule out the never misdiagnosis, which can be fatal for any patient, such an ischemia, an emboli, a dissection. But then the context of the patient comes to mind. So when you have the pace and the localization, you can also add the context to give you the differential diagnosis. And in this case, a very young patient, 23-year-old female, for sure, stuff that could make me hold my breath, like myocardial ischemia, it's less likely. However, if this patient has any risk factor for a hypercoagulable state, a PE could be possible, a dissection could be possible as well. Cardiac tamponade is another thing that, another cause of chest pain. I remember one of the first episodes of VMR that I listened on the podcast with Ravi and Reza was this like mnemonic of the, I believe it was a P, I don't even remember which, it's embarrassing, but the two P's,
Embarrassing for me, not for you.
the four P's and the two A's or something like that. It was like pulmonary embolism, cardiac tamponade, then dissection, MI, and something else that I'm missing for sure. And yeah, esophageal rupture is another good one. So I think for this case, I'm going on the branches already, but I will prioritize the lungs, the heart, and then the context of the patient. And acute, I will, as I said, rule out and never misdiagnosis for the acute chest pain. I don't know. What do you think, Roy?
I think that if you've been listening for the last 2 minutes, you're like, wait, how is Valley not a cardiologist and a pulmonologist at the same time? That really maps out the landscape that we have to study very, very well. And Valley, you'll be a teacher sooner than you realize if you don't get that feeling already. Whenever people feel like they don't remember what you taught them, it's not because they didn't remember, it's because you have to improve your teaching skills. So I will try to increase my chest pain teaching, but I think you hit on a really, really key modifier here, which is that this is chest pain, and you taught us what to think about. And you also focused in on something very key, which is that this patient is 23. And that is a big variable to study, because often when patients come in with chest pain and they're older adults, the pre-test probability of coronary artery disease is very, very high. And so here, all you can say is, what does the fact that she is 23 change? It doesn't change much else, really. Pericarditis is still on the table, aortic dissection is still on the table, pneumonia, pneumothorax, PE, esophageal disease is all still on the table. The only big variable that has changed dramatically is the risk of coronary artery disease, which, absent any familial disease or other mild variables, that's the thing that's been removed from the calculus. So that's what I would emphasize, is chest pain, 4 + 2 + 2, and all the A's and P's and whatever. But more importantly, what happens when a patient is 23? Nothing. All those things, PE, pneumothorax, all of them have plausible reasons to occur in a patient who's this young. The only thing that has changed is the risk of coronary artery disease has plummeted. And as Vale outlined, you can have a myocardial infarction or an acute coronary syndrome unrelated to coronary artery disease. So those things, if this person looks like they have a heart attack, we'll have to entertain the possibility of non-CAD related heart attack. So excellent summary, Vale, and I think we'll have to follow all the leads that you said, and hopefully Ravi will give us some clarity with the next aliquot.
Oh, great job, Vale. So continuing on, this pain was described as 10 out of 10.
Well, Ravi, I think you accidentally hit the mute button in the middle of that.
Oh, okay. I'll start again. So I put some of the stuff in the chat so that the scribe can capture that. So the pain is described as 10 out of 10, sharp shooting, pulsating. It's located in the midsternal region, and it radiates to the upper back and also the throat. So she was apparently drinking Gatorade and was swallowing the Gatorade and also talking at the same time, and suddenly the pain came on. There's a sensation that she has almost like this globus sensation and needs to burp, but wasn't able to burp or relieve her discomfort. She's been having throughout the rest of the day a mild cough, and she was also then out walking in the rain without a jacket. So she's able to talk in complete sentences, no difficulty with trying to express herself, but this pain has been nagging her for the entire length of the day. Going through the review of systems, I'll put that in the chat as well, but the significant findings, head and neck odonophagia, cardiovascular chest pain, and respiratory, the non-productive cough, which I mentioned. And past history, anxiety, depression, no surgical history, no family history. Social history, drinks wine on special occasions, no smoking, occasional marijuana use, cut down from 2 to 3 times daily to once a day, used Molly twice in the past month. And I'll stop there at that, aliquot.
Thank you, Ravi. Yeah, okay, so this is really interesting because, of course, our base thinking, prioritizing the heart and the lungs, I think for the fact that it's been quite sharp and intense. When I heard that, of course, I thought, okay, so maybe this is something from our never misdiagnosis that prioritize the heart and the lung. But then also the fact that it worsened with, or that it started with drinking and swallowing, and then she developed odinophagia, that makes me think that the GI system, the upper GI system, could be involved, specifically the esophagus. And one of the never misdiagnoses is esophageal rupture and impaction. And so I think she does not have dysphagia, right, Ravi? Only odinophagia.
Only adenophage.
Okay, and then okay, and yeah, also like the mid-sternal region, radius to the back, could be compatible with an esophageal type of picture. I think points that will make us think about like cardiac or pulmonary here, I'm not seeing them at all. Like the productive cough, the non-productive cough while walking in the rain without a jacket, it seems very inspecific and mild, and no fever, which I think are facts that could make us think more of a pulmonary rather than a cardiac cause. So yeah, I think for this patient, I would like some sort of like maybe a barium study or a CT to see if there's anything compromising the esophagus, because I know it's an emergency, but I'm not really sure what else. And I don't even know what type of imaging, if it would contrast or not, I will get. So I would love your advice on that, Ravi.
No, Vale, I think you've hit the nail on the head here again by focusing in on the key piece of history, which you seem to be prioritizing her relationship with ingestions of things like liquids and solids, and you're discarding her history of symptom prominence with her coughing and in the rain. And I think that's the kind of analysis that you can do right now, is what is valuable to you and what is less valuable. And I'm right there with you, categorizing them the same way. And I think if we just go back to the big theme here, the big theme is a different one on chest pain, which is not so much what's causing it, but rather how do you get to the bottom of somebody who's coming into you for chest pain. And as soon as somebody says the words chest pain, you know they're getting a basic workup. They're getting an EKG, a chest x-ray, and some labs. And the question is, do you need to go beyond that workup in this patient? And I think the answer is yes. You've gotten some very prominent clues to the possibility of esophageal disease, which in the acute setting is best characterized with a CT scan. It's very hard to get acute endoscopy. It's very hard to get a barium swallow, at least in many institutions, as quickly as you can get a contrasted CT scan. Now, you may get lucky and you may catch the process being primary pulmonary with an x-ray, be it a pneumothorax or a pneumomediastinum, or issues with air leakage into the neck, which is rare, but something to think about with the constellation of symptoms described. So I think all that we can confidently say is there's too much signal for the esophagus not to move very quickly to looking at the esophagus in the most acute way that we can, is with a CT scan, as you alluded to. But I think we still have to hold the hypothesis that there's something primarily wrong in the lungs or wrong in the upper airway. And those, a lot of those would also be assessed by the CT scan, but you might have to consider neck imaging as well in this patient. A very unusual history. It's not common that patients with chest pain take us into the space of the esophagus and the airways, but I think in real life, you want to make sure you're not missing anything by doing the usual workup, but an early CT scan looks like it's in this patient's future. All right, Ravi, mic to you.
Okay, great discussion. So on to the physical exam. The vital signs: 37.1 temperature, heart rate 85, respiratory rate 15, pulse ox 99% Romaire, blood pressure 105/65. Generally not in any acute distress, and the exam pretty much normal. There's no crepitus of the chest wall, no abnormal respiratory sounds, no abdominal issues, no edema in the extremities. So I say generally, just to cut to the chase, normal examination. And I'll add in the labs. So Just wait for the scribe. So sodium was 138, potassium 3.4, anion gap 6, CBC normal, white count 8.62, hemoglobin 12, although slightly anemic, and platelet 277. And troponin was normal, and EKG showed heart rate of 55, T-wave inversions in V2, lead V2, V1, V2. I have to interpret. I don't have a interpretation, but V1, V2, and lead 3. So non-specific T-wave inversions. So they're not changed from the previous EKG. And I'll have imaging next, but I guess we can stop it and discuss if you have any ideas there.
Yes. So I think, well, the exam, I think, makes me think that some causes may be less likely. Like we were thinking about, well, now that I think about it, maybe not really, because if you have any vascular causes that are causing chest pain, like an aortic dissection or a PE, I'm not sure if they will be extremely like remarkable in the physical exam. I don't think so. And so with a normal physical exam, I wouldn't really rule out those things. What caught my attention is the fact that she's very thin. I'm not sure what's her height, but 44 kilograms seems very small, very thin. So maybe, and with the comorbidities of anxiety and depression, and this is the fact that I'm doing psychiatry right now, maybe, but maybe rule out eating disorders, which could, if she's been having like a lot of vomiting, could maybe she have done some damage to her esophagus while vomiting, and that could explain the pain maybe. I don't know if there's any cough with bleeding or anything like that. Then what also caught my attention are, well, the EKG is not really, because I know that the T-wave inversions in precordial leads are part of the, I think it's called the juvenile pattern, and sometimes the feminine pattern even, that in young patients it can happen, T-wave inversions in diffusing the precordial leads, and that's normal. Especially if we're lucky that she has an old EKG that's the same, so that's great. And well, the troponins, of course, make me think that something like myocardial infarction, less likely. Yeah, but I'm not sure. I think I would like for sure a CT. And I don't know what you think, Ravi, about, I mean, of course, esophagus is mainly my DDX right now, but also thinking about something like an aortic dissection manifesting like this. Could you see it happening?
Ali, I think before I answer that question, I just want to commend you for picking up all these subtle clues. You know, like the anxiety and depression didn't catch our attention originally. I don't think we even commented on it, but it is really that this is the power of clinical reasoning, which is that no data point deserves to be completely ignored. It's just that some things you choose to acknowledge their existence and put them in the background until further data comes. And it was really cool to see your connections that you were making. You were like, oh, look, low BMI, anxiety, depression, eating disorder, and then making connections with eating disorder and the chest. And I think that in addition to all the reflections you've made, I think so eating disorders in the chest, everything that you said, and I won't belabor it, but to also add one consideration, which is pneumomediastinum. And pneumomediastinum happens in patients with eating disorders, more bulimia than anorexia. And it's really not understood why. I think the hypothesis is that their connective tissue is a little bit less robust, and there's a high rate of pneumomediastinum in those patients. I'm saying pneumomediastinum not because it's more common or more likely than pneumothorax, but the exam with Ravi's excellent breath sounds makes it less likely that there's a pneumothorax, but something in the mediastinum will evade you on exam. It's very hard to catch a pneumomediastinum on examination. And so I think that I say all that with the emphasis that we might get lucky and see something on chest X-ray. And you might see evidence of that disease process on X-ray. So the path that I think, without commenting on what diagnoses are possible, because it doesn't matter what this person has, what matters more is what are you going to do about it? And I think there's a small chance we'll get lucky and see something like an pneumomediastinum on chest X-ray. But I'd emphasize that if you do see an pneumomediastinum on chest X-ray and you are in a resource setting that has access to CT, you probably will follow that up with CT. So Vale, I think this case is very unusual. Most chest pain ends up in a basic workup, EKG, chest X-ray, and the things that you picked up on from the very beginning, including the relationship with the event that happened, the ingestion, the Gatorade, and the globus sensation, you picked that up. And then you're merging it with very, very astute pickup of low BMI, anxiety, depression, equating that to query eating disorder. So now we're studying what are the mechanical complications of the hypothesis that this patient has an eating disorder. And I would say esophagus for sure, pleura possibly, but also the mediastinum. And we'll see where Ravi's investigations take us next.
Oh, great pickup, Wally. I really like that hypothesis. I'm going to share screen, give you the images. I think you really get the impact of what the patient is manifesting with when you look at the images. I'm just gonna, there we go. So this is the X-ray, and it doesn't really, I don't really see anything there, but you're right that she's tall and she's very thin. It's quite remarkable if you look at the skin here. So the patient is a very thin individual, but here's a CT, and it is exactly what Ravi had mentioned, that we would be curious to see or have a high suspicion for pneumomediastinum, so you can really see how severe this pneumomediastinum is. And per the report, there's extensive pneumomediastinum noted extending all the way into the neck. No evidence for pneumothorax or lung consolidation. And somebody had mentioned in the chat about lung blebs and so on. So we don't see any emphysematous pattern, no blebs there, no evidence of PE aortic dissection. There is enlargement of the right heart and some cystic changes in bilateral lung parenchyma. So differentials could be LAM, eosinophilic granuloma, or LIP. So these were the images. Any comments or reflections, Val, also Ravi?
Oh, I'll let Vale chime in with her comments, but I would just say, Ravi, if you want to go to the X-ray, I think in retrospect, when you have a pretest probability of the possibility of pneumomediastinum, there is a subtle piece of clue on there. If you want to show people, because I think it's if you weren't Vale and you didn't set up this case as sharply as she did to even look for it, it's so easily missed. But I think what you see there is a stripe of air. Yeah, exactly. Ravi, I'll let you point it out. It's actually very subtle, but you see black and then white. And that is a subtle clue that there's mediastinal air. It's way more apparent if your mind is looking for it, because you're listening to Vale discuss. I definitely would have missed it, honestly, if you just showed me this X-ray blind. But in the context, I think there. All right, Vale, I'll stop talking and pass the mic to you.
Oh no, you're too generous, Ravi, because you totally picked it up from the first aliquot. And I'm so blown away by this case. I didn't know that people living with eating disorders had a higher rate of pneumomediastinum. It's a really interesting fact. Yeah, I'm curious if there's is it like a spontaneous pneumomediastinum, or could it be caused by any other thing, like the esophageal rupture theory was ruled out? Because that could also, right?
Yeah, so Vale, we weren't quite sure what happened, but possibilities are, one could be excessive marijuana use causing alveolar damage. You're right about the thought of vomiting secondary to possible eating disorder or rupture of a cystic lesion, but none of these were confirmed. And surgery, CT surgery, saw the patient. They said it was self-resorb, and after that she was fine, and then discharged, and did not have a reoccurrence in the outpatient setting. She was followed up.
Thank you for this case, Ravi. And I love one of Sheima's comments about the marijuana-induced hyperemesis syndrome. You know, even in the absence of an eating disorder, it could still be a risk factor. So yeah, I think this is a really great case to reflect on the multiple causes of chest pain, and a great way to remind us that it's not all about the heart and the lungs, that it goes way beyond that, and we should look on the spaces that we usually miss. Because I totally agree with Ravi that if we hadn't thought about, or that he hadn't brought it up, the idea of a pneumomediastinum, I probably wouldn't have noticed the little line there on the chest X-ray, and that for sure makes a difference because, a chest X-ray is way more accessible. So making a diagnosis like that just from that simple imaging, that's really a flex. So I'm gonna keep this case really in my back pocket. Thank you, Ravi.
Yeah, no, Ravi, I couldn't agree more. Like Thursday after Thursday, like you're humbling us with these incredible cases. And, the truth is that this is, that you can easily see how if you don't set yourself up to see that X-ray finding, you might miss it. And it's very, very humbling. And I agree with you, Vale. I think that mediastinal diseases are very hard to diagnose in patients presenting with chest pain. And it's I think we can spend a lot of time reflecting on that, but I think it's partly because the mediastinum is sandwiched between the lungs and the heart, and we have such rapid access to the heart with an EKG and with a volume exam, and we have such rapid access to the lungs with an X-ray and our stethoscope. And so the stuff that is buried between them, namely the mediastinum, can easily elude us. So, and think about this, like this patient has this like scary sounding thing, air in the mediastinum. And if you review her symptoms, their symptoms are like, kind of hurts a little bit when I eat or swallow. And yet there's air in her mediastinum. And this goes to show you how terrifying this disease process is, but also how maybe as speaking as an internist, maybe are disproportionately worried about pneumomediastinum. It sounds like you just like let her hang out and let her resorb the air. So I guess it also depends on why the patient has a pneumomediastinum. But yes, there's no way I would have thought of it if you hadn't picked up on the eating disorder. And the eating disorder pneumomediastinum connection is one of those like step 2 kind of things that I just have heard about. I have yet to explore it. So my homework today, after we're done, is to try to understand the link between that eating disorder and pneumomediastinum in more detail. I don't know anything more than just like the brainwashing that step 2 CK did for me. And it clearly helps sometimes. All right, Ravi, we'll pass the mic to you for any final reflections before we hear from Leah.
And I just want to say, yeah, great job, Val. That was an incredible walkthrough. You handled chest pain like a professional. So the 4+2+2 and the A's and P's that you had mentioned. But I just want to say, young people, chest pain in young people is very scary. And if you look at the data, a lot of young people presenting to emergency rooms with chest pain, a lot of people are like, oh, you're too young to have coronary artery disease or something along those lines. But there's some very scary pathologies like spontaneous coronary artery dissection and other things that could manifest in some patients, but you got to do your due diligence and work the patient up. And this was something that definitely gobsmacked me. I wouldn't anticipate a ugly looking CT like this. And like Ravi mentioned, the patient's just like, I'm having a few symptoms, but is absolutely fine. So definitely a great sort of case, I thought, to present, to look at the bottom part of that schema of the 4+2+2 and respect the esophageal causes. Mike, back to you.
Okay, so first you have to tell me whether there's a lot of background noise or not, because someone just started drilling outside at this moment. Okay, perfect. Well, so we had this discussion about chest pain, which is a common symptom that we encounter a lot, but Ali really took a new kind of approach by applying also the neurological approach for time course and localization. And she also mentioned that there are, of course, these no-miss causes where we have the 4+2+2 schema. But in this case, actually, it was really helpful to think about localization when it comes to chest pain, because you not only have to think about common causes like the lung, heart, abdominal causes can also present as chest pain, but generally think of what is inside the thorax. And here we actually needed to explore more than just our basic chest pain workup with the X-ray, the EKG and the labs, because we were concerned also about this might be an acute esophageal rupture, for example, and the CT would have been a helpful diagnostic imaging there. And then also, because we had this patient who might have had risk factors or who might have struggled with an eating disorder, we thought about what mechanical consequences that might have So we mentioned the pneumomediastinum. It might cause damage to the esophagus and predispose it to rupture, and also involve the pleura. And then finally, a few clues for the examination of the pneumomediastinum. So helpful imaging can be the chest X-ray, where you can also see subtle lines of the air. And to further investigate that, you can, of course, do a CT scan, and just be aware that it might have a normal clinical examination, just as vascular processes also. So when you think about chest pain and consider a pneumomediastinum, make sure you go further than just the clinical examination. So yeah, thank you for joining today. And this was a really great discussion and fascinating case.
Yeah, like so short and sweet. It's just perfect, like hitting all the highlights and ending with an emphasis on how subtle the exam can be, but how important it is to take a picture. That's superb. All right, thank you all. Really appreciate you and hope to see you at the next VMR. Bye.
Bye, everyone.